Good afternoon, everyone, and welcome to today's webinar. I'm just going to give it a couple of minutes as people are entering the room before we start. Welcome, everyone. I see more coming through the link now. And Maria, I think we'll get underway as more people come in. We've got a tight time frame today. Hello, everyone. I'm Anne Livingston. I'm the Executive Lead of the Australian Aged Care Industry Information Technology Council. Welcome to our series of webinars that have been concentrating on our relationship from the Aged Care Industry Technology Council with various key researchers around the country and indeed internationally. And I welcome particularly those other research entities and personnel that are joining us today from both all around the countryside and internationally, and I welcome those international guests today. We would like to acknowledge before we start the traditional owners and their custodianship of the lands in which we meet. I'm on Quandonamooka land, the beautiful land down joining the Southern Moreton Bay Islands. And on behalf of the Council, I'd like to pay our respects to ancestors and their descendants who continue a cultural and spiritual connection to country. We recognise their valuable contributions to Australia and indeed the global society. In terms of housekeeping, a couple of key issues before we continued on today. Just in the interests of efficiencies and noise control, all your microphones have been muted, but don't let that stop you asking questions. And those questions can be put in the Q&A panel, and we will come to hopefully all those questions before the end of the session. This session is being recorded and will be made available in the coming days. If you have any technical issues during the webinar, please use the Q&A panel to discuss them with our team from the Council in the background. Without any further ado, I guess it's my pleasure to introduce to you our speaker today. Our speaker is Maria Inacifo of the Registry of Senior Australians, and she's going to talk to us today about using Australia's aged care and healthcare data to inform care and policies reform. Maria is Director of the Registry of South Australians, or ROSA as many people know it, at the South Australian Health and Medical Research Institute and the National Health and Medical Research Council Fellow. ROSA is a platform developed to support monitoring and evaluation of the quality of ageing and aged care services. And Maria's work has the goal of identifying good models of care, areas in need for improvement, risk factors for poor health outcomes, and opportunities to improve health and well-being of older Australians accessing a variety of aged care services. It's great to have you on board, Professor, and welcome on board. Thank you for your presentation.
Thank you so much for that introduction, Anne. I really appreciate it. I appreciate the invitation to come here today and share with everybody a little bit about ROSA's work. I will share my screen now, so just give me 1 second and hopefully the transition will be smooth. Can everybody see the slides now?
We can, thank you, Maria.
Fantastic. Wonderful. So I thought what I would do today is introduce a little bit about what ROSA is. There it is, sorry. What ROSA is and the work that we do here to really learn from the information that's available at a population level in Australia and derive new information that we can use to support clinical practice and policy as well. So as a bit of background, my team is based here in South Australia. We were set up to develop a clinical quality registry and a data platform to monitor the health, the service use, the medication use, the mortality, and other health outcomes of older people that are accessing aged care services in Australia. We were established in 2017 with some local funding from the state government, and now through the Medical Research Future Fund with some infrastructure support. We link information from both the aged care sector that's available at a population level in Australia to the healthcare sector, so that's available both at the federal level and the state level, as well as soon the social welfare sector. The aim of all the work that we do here has always been to improve the quality of aging and the aged care services that are provided to Australians. And my team today has about 20 individuals based here in at SAHMRI, with appointments throughout various universities in South Australia. And we're really more technically focused, and what we do is partner with the larger team of collaborators that are involved in the development of ROSA to do the research that we do. So most of my team here are epidemiologists, statisticians, computer scientists, programmers, pharmacoepidemiologists, and so on. I'd like to share the slide before I introduce what ROSA is to people, so that you can get a sense of what it is that we've done here. And essentially what we did is we set up we set out in 2017 to establish a registry in South Australia of every older person that had an ACAT. And the idea was that we were going to integrate information from their aged care eligibility assessment to all of their service records, and then on to their Medicare records, their pharmaceutical benefits scheme records, as well as their state-based hospital records that included ED presentations and ambulance service data. So we did that, and that's called the Registry of Older South Australians. And to date, it has about 29,000 entries, of which are for about 26,000 people. So every South Australian that has an ACAT is given the opportunity to opt out of the registry, and we can identify the facilities and certain information about that cohort that is really useful for some of the things that I'll mention later. But at the same time, parallel to setting up this registry here in South Australia, we set up a national historical cohort that included a lot of the same information that allowed us to start a lot of the research questions that we had, but it now has proven itself to be an incredibly valuable infrastructure for us to continue to do research, because what this resource has to date, it is a cohort of people that have accessed aged care services from 1997 to 2020. It has about 3.5 million individuals who've ever accessed any kind of aged care services in Australia linked to their healthcare service records. So it is the volume of that information allows us to do the type of research that we couldn't do it otherwise, and also allowed us to develop a lot of the tools that I'll also mention later on that were implemented in the registry. So the ROSA actually is 2 data collections, a prospective consented cohort of individuals in South Australia that has some identifiable information, and a historical completely de-identified cohort of individuals that captures about 3.5 million individuals. The data collections that are part of ROSA, that are integrated within ROSA by the Australian Institute of Health and Welfare, and then a subsequent 4 other data integrating authorities from different states, are all listed here. So there are things like the information from the National Aged Care Data Clearinghouse, the information from Medicare, from PBS, and then the variety of state health data collections that I mentioned before. Now, really importantly, this year we also got approvals to link 3 new data collections into ROSA. So next year, hopefully, when we update this data set as well for extend this data set in time a little bit, we will also have the Department of Social Services data over multiple individual occurrences, which is called the Domino data set, that captures all the Centrelink information, as well as the Australian Immunisation Register for the obvious reasons, and also the AROC information, which is information for another registry that captures information on rehabilitation of individuals that are hospitalized for specific types of procedures and need in-hospital care, in-hospital rehabilitation services. So when we bring that information into ROSA, we organize that information into, the domains that we use and derive new information from. And we use that information within the department here of ROSA to conduct a lot of research, to develop risk profiling tools that we hope to implement at the point of care that I'll share with you in a bit, to develop reports that people can understand their practices, and I'll also share that with you in a bit. And then also to create educational material, knowledge translation tools that are available on our website that summarize information from the studies that we've created. We also support a range of consumer activity information. We're really committed to public dissemination of the work that we do and making sure that the information is not just kept in silo in an academic environment. And then a lot of other activities as well. Over the last 5 years, ROSA has, been able to deliver quite a bit of new knowledge, I think, derive new knowledge from this cross-sectoral data linkage. We have over 70 academic publications now. We've provided reports to a number of professional societies, as well as 8 to the Royal Commission, for example. We've done a lot of community engagement activity, as I mentioned, and we try to get the word out on the work that we're doing quite a bit. We also have brought in new groups that throughout Australia that were really important for the areas that we wanted to focus on. So we have a number of new collaborations that were established after ROSA was formed that include, state-based collaborations around reducing hospitalization rates. This is the STAR-SA collaboration that is noted here in the slide. But we've also engaged and worked now with the Australian Dementia Network, the Royal Australasian College of Surgeons, the Warraparinga SAHMRI Health Research Team, to do some Indigenous and Aboriginal work, primary care groups, and so on. The way I have structured my presentation today is just to give you a brief introduction of some of the highlights of the work that we've done here and kind of the information that was derived from this work and how it has informed different aspects of what we're doing now. So when we first received this information from the data integrating authorities, we spent a lot of time trying to understand who they were. We spent a lot of time trying to describe who were accessing these services, what did they look like, and how has that changed over time. So we have publications that describe the increasing prevalence of comorbid conditions on the individuals that are presenting to starting to receive home care packages and residential care services, for example, the increasing number of medications that they have been received over a decade, the really high increase in frailty of these individuals when they're showing up at starting their services. We've also looked at the increase in number of service access and how it has changed over time, how even though there is a cap on the number of services, it's obviously that there has been an increase, much greater increase in the use of home care packages than there has been a decrease in the use of residential care services, for example. We spend time looking at mortality and other major health events after people entered services. And the figure that I show you here in the slide is actually looking at the standardized mortality ratio of individuals in the first year after they've entered care, and particularly here is residential care, in comparison to a comparable age and gender matched cohort in the general population. And what to describe here this a bit, like there's nothing here that we didn't understand, but we quantify just how different these individuals are from their counterparts in the general population. So there is a much higher mortality rate in these individuals as we would have expected, but there's also, it depends on the age and the sex. So the younger you are when you go into residential care, the much higher mortality rate you have than somebody who's older when they go into care. Because of the nature of aged care and some of the challenges that it encounters, and also the makeup of my team, which includes quite a few pharmacoepidemiologists, we've spent a lot of time in the last few years trying to understand the quality use of medications in this setting. Some of the work that we had started, and then the Royal Commission actually asked us to provide to them, which they use for their interim report, was around the dispensing of psychotropic medicines for individuals once they've entered residential care, because I think there was a common belief that that there was quite a substantial increase once they've entered care, although there were individuals that said, well, they had already been on prior to entering care. So we've actually did that analysis in quite a bit of depth. And what we found is that that is true. In the year leading up to entry into permanent care, there was an increase in the use of psychotropic medicines, but there is a marked increase, even more so, in that first 90 days after entering care, which then plateaus. So it never actually goes down. We provided that information to the Royal Commission. We also published that in the Medical Journal of Australia. We've also done a lot of work around the utilization of some of the most important, I think, medication issues in aged care. So we've done a lot of work around antibiotic use in aged care, which has increased quite substantially over the years. We've looked then at services that can be used that could potentially mitigate some of the issues related to medication use. So Dr. Janet Sluggett is a postdoctoral researcher at University of South Australia and with my team, who's done a lot of work around the access to the variation in access and then the outcomes of medication reviews, which is a service that can be subsidized by Medicare when it's done collaborative with a general practitioner. And that could potentially offer quite a bit of benefits for residents, but is not widely used. So we've done a bit of work characterizing that access. So we know that only about 30 to 40% of older people, when they enter residential care, actually access that service, even though it is one of the recommendations. And then the variation nationally, which is quite substantial. There are facilities that every resident that walks in the door has one of those scheduled within that time period, but there are many that don't. And then I'll talk a little bit about the outcomes that also in a second. Also, since about 50% of the individuals that are in residential care have dementia, and about 20 to 25% of the individuals that are receiving home care packages have dementia, we have, in collaboration with the Australian Dementia Network, characterized our cohort first of individuals in residential care and home care really well, so we understand who they are and how they compare to international and national cohorts of people with dementia. So that way, when we are doing studies on them, we can understand how representative they are of other people. So we've done a couple studies that really characterize that cohort of people in residential, in aged care that have dementia. But then we examined different aspects of what the Australian Dementia Network has determined were important in regards to their quality of care. So, for example, we examined the use of anti-dementia drugs on these individuals. We looked at the incidence of hospitalizations for dementia or delirium-related issues as well. And then also access to primary and secondary care, which could be incredibly helpful for them. And what we've done through this work is show that, again, this information can be used to measure and to try to understand national practices in regards to a lot of the care that people with dementia get when they're in the setting, but also that there is a lot of variation. And that's what this figure here, for example, show you. This is the adjusted proportion of people receiving a antipsychotic. This is actually the cholinesterase inhibitor. I can't ever say that word, or memantine in 2015 by residents of by aged care. Sorry, this is aged care users, not just aged care residents. Sorry. So you can see there's quite a bit of national variation. This is at the geographical area, statistical area 3 level. So there's about a little over 300 of them nationally. And there's substantial differences in the use of this medication in Australia for people with dementia. A lot of the work we've done was also focused on examining how aged care services are used. I know there's an enormous amount of information in regards to this on the report of the operation of the Aged Care Act that gets released by IHW and the department every year. I know there's an enormous amount of information about this and a number of reports by the Australian Institute of Health and Welfare as well. But what we tried to do was dig into some of the questions that hadn't been necessarily examined in depth before, that would complement a lot of that information. So one of the things that we did was try to examine what some of the factors that were associated, for example, with people having ACATs and not uptaking their approved services. And that was one of the first analyses that we did around the utilization of, the ACAT assessments and then the services that the people received from there. We also did quite a bit of work around respite care and how the use of that has changed over time, and how it actually delivers on its intended purposes of keeping people at home longer. And this is a really lovely, I think, example of how this information can be used. We all hope that respite is delivering what it is, and the use of respite has changed quite dramatically in Australia. So it used to be that people used it for a couple of weeks and they went home, but now more and more so, up to 40% of people use it right as an entry or gateway to permanent residential care, and that's very obvious from the data that we're analyzing. But if people do use it as it was intended, they use it once or maybe twice and then go home and do give their care a break, the total numbers of days that individuals spend in care is actually smaller. So that is a really good, I think, showing good value of such a program. We also, and you might have heard of this specific study, we examined the effect that waiting for home care packages had on outcomes like mortality and then transition to permanent care once somebody did eventually receive their home care packages. And from that study, we found that in the longer term, waiting more than 6 months for a home care package did increase people's risk of mortality, as well as their transition into permanent residential care faster, which, again, this was used in the interim report by the Royal Commission as evidence to, to decrease that amount of wait for these services. Because in the longer term, even though the people that were receiving the services were actually more frail and, the ones that were identifying as having higher needs in the shorter term, in the longer term, even the ones that could wait a little bit longer were being affected. And then finally, we examined things like what were some of the factors that were associated with people benefiting from transition care services that are also offered under the aged care service programs. We have, in the last couple of years, started a new piece of work around the integration of primary allied healthcare and specific specialist services for older people in aged care services. And so you will be seeing a lot of work coming out in this area. The first couple of years, we spend our work examining the access to these services. So we have quantified and looked at trends over the years of access to all of the primary health encounters, all of the mental health encounters, all of the eye health service utilization, for example, and then specific things that we were particularly interested in, like the medication reviews, and so on. And what we have done is we looked over time how that has changed, but we also looked how it changed once somebody started their service. So the figure here is showing you the change in access to a lot of these Medicare subsidized primary healthcare services before and after somebody entered permanent residential care. And we've done this analysis for home care and other things. The next step of this work, which I think is the much more interesting that will be coming out in the next couple of years, is our examination of the outcomes that these services actually deliver for these individuals. Because we can tell that there is generally not great access to these services, even though it has increased over time. There's quite a varied access over the country to these services, but we don't understand, and we haven't quantified, and a lot of studies haven't done this yet, about just how much does accessing a lot of these services does provide in benefit of reducing hospitalizations, reducing falls, reducing mortality, and so on. And that is what we're doing. But instead of doing one service, one outcome, what we are planning on doing is a global examination of the services, the trajectories, the different relationships that the services can have to each other, and a number of other things that maybe will indicate how models of care within the aged care sector works best. That's what we're trying to get at. So watch this space, because there will be a lot of work coming out from us in the next couple of years around this area. And then the part that I hope some of you have heard of, become familiar with, is that one of the main things that we did was develop a set of indicators that could use the information that's captured within the ROSA data sets to monitor quality and safety of care that was provided to older people in Australia. And that's what we call the ROSA outcome monitoring system. And it really, all it is a set of 12 indicators for residential care and 15 indicators for home care that are agreed upon measures of quality, either of access or of outcomes of service that should be monitored on an ongoing basis that might provide some benefit to providers if they're interested in understanding how their practices are and how they compare to others. So we developed a system using its cross-sectoral information. There is a number of limitations with doing monitoring at this level. One of them being the timeliness of this information, because most of the information that we are reporting on right now is quite old. It's 2019, as I'll mention in a minute. So it is unfortunate that it can't be used just immediately for quality improvement efforts, but there is a number of benefits to using this kind of information. Well, one of them is the obvious non-biased nature of the data sets that we're using. The other one is the obvious lack, the much lower burden on the providers in monitoring this information, because this information can be captured from existing data sources. And so there's an immense amount of value in here. And then also the other thing that we can do really well is provide risk-adjusted measures. We have a lot of information about these individuals. We know a lot about them, and we have models that we can use to account for the differences between the facilities. So when you are comparing quality indicators across facilities, you're talking about apples and apples and not apples and oranges. And I think that that's a really important part of the work that we've done. So by developing those indicators and that system now that we have, so we have technical specification, we have a reporting structure. The Royal Commission actually used those quality and safety indicators for a number of their reports. And they actually were able to get information that we didn't have yet, the time-wise, and use our specifications to recreate these indicators in more recent data. And in addition to the reports that we created for them, they've also recreated our indicators and used them in a number of other reports that they produced themselves. And I'll mention that in a minute. But we also have a lot of publications that describe both the development of these indicators, how we arrived at the definitions that we did, what are all the the specifications around them, and then a couple of papers that we've written now that examine different questions about the indicators as well. So for example, Professor Jill Caughey in our team has published recently a letter in JAMDA, which is an aging journal, that talks about the changes over time of some of these indicators. And the figure that I have here on this slide right now is just showing you the adjusted antipsychotic use in residents of 2,500 facilities in Australia in 2016. And I think what is important about this figure here is that, unlike the other figures that I showed you before that showed a bit of variation, there's very little variation in regards to antipsychotic practices nationally. But that's the kind of really important information you can derive from doing this work and understanding practices nationally. And then here is just a bit of a taste of where we're hoping we're going now. So we've developed this way to monitor individuals. There's, as I mentioned, 12 indicators for residential care, 15 for home care. But so what? What can people do about it? Like, other than providing the providers with that information and acting on it, is there any other things that can go along with the provision of that information that could be useful for providers and potentially eventually for individuals going into care as well, that could help manage or modify some of the things that we know put them at risk of having those events? And that's where this risk profiling work is coming. So we are developing methods, like new models now, using statistical learning, machine learning, traditional statistics, and different methodology in different ones. We're still trying out what's the best here for us, on how do we develop prediction models that identify the characteristics of the individuals at very specific points in their aged care journey that tell us what the likelihood of them having that event is in the short term afterwards. And then what are the factors that could be potentially changed or modified that would reduce that risk from happening. So we've developed quite a few of them now. So we have a pretty good understanding by using our data of what are some of the triggers and what are some of the things that contribute the most to some of these events happening. Some of it is, well-documented risk factors for these events, but some of it is actually not necessarily, and some of them are very specific to the Australian setting, like, facility size and ownership and location and all of that. So there is quite a bit of really interesting information that we're developing now. I think we've developed 6 or 7 of these now. And the idea would be that eventually this information can live in a place like My Health Record. The individual is going into residential care. You can open it up, and by the magical integration of all the information that's already collected on these individuals through the data collections that I mentioned are captured within ROSA, you can identify the risk of these individuals have these events in the short term, and then provide them with information on how to mitigate those risks. But that's a very, this is our long-term plan, and hopefully where we'll get a few years from now. So I joke that my department got caught up on the storm that was the Royal Commission, because we hadn't been around for very long, but we got involved in a lot of different ways in the investigations, and it was really, really exciting from a researcher perspective to be involved in something like this, because it really allowed us to see the information that we were providing making an impact on some of the recommendations that were happening, and then some of the now reforms that we hope are going to be happening. So it was really quite an honor to be involved in such a process, and it was just an incredible experience, and one that I'm really, really hopeful will change, and it help improve a lot of the, a lot of things, and that potentially we could provide some information that would help. So as I mentioned before, we led 4 reports that were commissioned by the report, but there were also 4 other reports, and I have been listed here, that use those quality and safety indicators that we developed. And at that time, only the residential care ones were developed. So this was only focused on residential care. And you can, I'm sure you're familiar with a lot of these reports now, but those measures that are included in there are all based on our work. And we all know what happened at the end of the Royal Commission, and we like to think that there's quite a few recommendations that were potentially influenced by some of the work, and we're really happy to see them. They're probably a little bit different than some of the things that you're most interested in, but there are things that we are very interested in, and that's, around quality and safety monitoring nationally, medication management, things around data governance and data access and integration, and then also research funding, for example, and oversight over the next few years. And I bring this up only because, this is an incredibly ambitious plan that I don't know how they were able to summarize in one slide, but it's really quite amazing what the opportunities are in the next few years and the reforms that are happening. But really what I hope is that we can continue to provide information that will inform some of these reforms, because a lot of these reforms still need quite a bit of, they're very high level at this point, and still need the detail. They still need the evidence to really support how they're going to actually happen and how they're going to be best implemented, and then also how they're going to be monitored once they are implemented. And I think that that's what we offer, is the capability of, the understanding the national data collections, creating this resource that exists now that hopefully we can use to monitor what some of these reforms will do. And we have been involved in a couple of the beginning reforms, which is has been a really great experience. We were involved, for example, on the expansion of the quality indicator program that is going to be happening, I think, later this year. This was recently announced in regards to domains that were identified that will be. Right now, there's 5 domains that are captured by the quality indicator program and 8 indicators. There will be an additional 6 domains added. and they are the ones that are listed here on the slide. So, and I think that these are absolutely the domains that should be implemented as part of the program. We also were briefly involved on a scoping study on multidisciplinary models of care in residential aged care homes. And this just got released, I think, last week, and is around, allied health services, restorative care, reablement care in residential care. And what ROSA was able to provide for this development was some evidence around, the utilization of some of these services and the effect that it has on some of the major outcomes that something like that can potentially affect. So that's, showing another example of some of the work that we can do using a resource like ROSA. And so now I'm just going to move on into the what's going to be happening towards the end of this month, early October now, and that is that the ROSA Outcome Monitoring System Aged Care Report for South Australian providers is going to be released. As I mentioned before, the registry that we have set up in South Australia has some identifiers. So we have identifiers on the providers because we have consent from the individuals to obtain them. So for the 245 South Australian residential care providers, we now have reports for the individuals that are captured within ROSA around quality and safety monitoring. Now, this is an example of the report without the content. By the end of this month, we're just waiting for like final releases of the numbers from SA Health. We'll be able to share this with everybody so you can see what the South Australian performance is for this specific cohort for 2019. But providers can also access their own report. So for about this year, because we had agreed before we did the reports that if there were facilities that were too small, we were not going to report on individual providers for trying to minimize the risk of identification of individuals, for example. So for about 87 facilities in South Australia that have more than 20 residents, we can provide them with their specific facility report. We can provide an additional few reports for providers if they want at the aggregate level of the provider, not necessarily at the facility level. And what that report has is a bit more in-depth information about their performance for each one of the indicators and how they compare to the other facilities and how they compare to other benchmarks that we also have available within that data set. And all of this, as I mentioned before, is risk adjusted and uses the technical specifications that we created on how to monitor these specific measures. So we're really excited because we've been working towards releasing this report for over 5 years, and this is going to be the first time it's going to be released. Then we were going to report on the financial year of 2019-2020, but unfortunately we have 3 months of COVID in there. And since it was the beginning of the pandemic, we decided that we would report on the calendar year of 2019 this year. If people want the 2019-20 financial year, we can run that report for them as well. But I think it's probably more helpful if we wait until we have 2021 data and then get a full year of actually the experience of COVID. And it will also give my team a bit more time to understand how COVID has affected some of the things that we have developed. So we still need a little bit of time for that. But with that being said, some of the analysis we have conducted looking at changes in trends and most of these indicators over time shows that they've all been very, very, very consistent over the years. There's been very little change. If the changes that we have seen have actually been on the direction that you probably don't want it to go, which is up instead of down. So anyways, I think there is a lot of value still in receiving these reports, and hopefully the South Australian providers that are on the call today, when you are ready, contact us and we can start the process of getting the documentation from you to be able to release your report to you. So it's important to note that only a provider can only receive their own report, and only if it's approved by their leadership within the organization. And I just want to acknowledge everybody that makes ROSA possible, all the people in our steering committee, our advisory committees, all the individuals that give their consent for us to use their information, but all individuals that are also included in the data set, the data integrating authorities who make bringing all this information possible for us, and then the funding also that makes sure that we can keep the lights on here. And that is all I had for you today. I'm happy to take questions now, and this is my team in case. Yeah.
Thank you very much, Professor, for such a comprehensive presentation. I've got a number of questions that have come directly to me, but there are, I'll go first to Professor Greg Alexander from USA, who's asked, how is data governance, access and integration measured and reported by ROSA?
So the data governance that is in place right now is that we need to receive institutional, statewide, and federal level ethics approvals for access to all this information. So all the data custodians, the individual data custodians, have stipulated requirements around the use of the data that we have in order for that information to be available to us, and then in order for the data integrating authorities, which there's 5 of them involved, to make it all happen. Then internally, we also have our own governance process and access, and less so, I guess, integration within our team. So within our team, we have a structure of only the questions that have been, ethically approved, and obviously the access given to us by the custodians can be answered. We have a process for which each researcher in the larger ROSA team has to justify in quite a bit of depth what the question is and how it addresses one of our aims. And then they have to be approved as well to access the information by all the different relevant data custodians and data integrating authorities, and also where our data actually lives. And then they can access that information and use the information. So it is a very complicated and actually lengthy structure. And that's for the general data access of ROSA. If there are questions around specific issues, like for example, Aboriginal and Torres Strait Island research data, then that has another governance process. And that is one, we have an advisory committee that is in charge of reviewing any incoming requests and making sure that it aligns with the principles of Aboriginal research ethics, and only if they are approved by then and have their support and involvement can they go on as well. So it is a really kind of complicated and complex structure, but we've made it happen, which is good. Yeah.
That's fantastic. And thanks, Professor Alexander, for joining us again in our webinars and in our work. Look, I've got a number of questions that I'm going to try to group together, Professor. A bit of state and territory envy of South Australia, I think I would class them as. Just complimenting South Australia for its initiatives, and about being quite interested in the data that those South Australian providers will be able to access shortly and be able to influence their practice. But generally, I guess the question from many of the respondents today is, are you going to be able to do that sometime in the near future for other states and territories?
We would love to be able to do that. The problem is we don't have consent from individuals nationally to re-identify any of the information, and the provider's information is considered protected information that cannot be re-identified in the fashion that we've created the historical data set. I'm always the optimist, and I think that there are avenues for that to happen, and one of them would be the Department of Health would have to make that available to the Australian Institute of Health and Welfare and allow for that to happen. How that works I don't know, but it is possible. And if that was possible and that was given to my team, we could do the same thing. But the problem is, under the current ethics and governance arrangements that we have, that is not possible for us to do for other states. The only other way to do it would have been to roll out something similar to what ROSA Registry in South Australia is. And that would include enrolling, over 160,000 people nationally every year, which the cost of that is just, something that we can't cover at this point. The investment in ROSA to develop that in South Australia and get all the ACAT teams to enroll individuals into ROSA and give our information about ROSA to South Australians was enormous. And I don't think as a research team we could do that nationally, but I could see it in a different venue in a different manner, hopefully, if the federal government decided that they would make that information available. And then, that could happen. So
by the information the comments I've been getting through, Professor, I think there's an overwhelming support for that nationally, and perhaps we can pursue that offline.
I would love that to happen. And I was just going to add, what we can do at this point to help inform some practices is give you a geographical analysis. So we can go down quite at a small geographical units. And, obviously you're going to be mixed up with other providers that are down the street, but it might give you a bit more about the current practices in your area. So that information I can give you. So just throwing it out there.
Professor, I think the question just posted in the chat pane here, what a great achievement in such a short period of time. Congratulations. What were the key challenges you faced during this journey, and how have you addressed them? Good question.
It is a very good question. And, there's a few achievements, there's a few challenges. I think, to me, still the biggest challenge here has been the ethics and governance issues around making the resource of the historical ROSA happening. And they continue to evolve every year, and we continue to have to address new challenges as legislation changes, as new requirements change about how to make this information available. And I almost get the impression that things have gotten harder and not easier to make such thing happen over the years here. So that is something that it requires a dedicated person and a half these days in my team to just do the management of the compliance to ethics and governance that are required between the states and the federal government to make this happen, which is an enormous amount of money and investment, obviously. So that is one that we just keep dealing with it and hoping that we will have infrastructure support to continue to fund that position, because it is a key position to make this happen. The other I think that's probably one of the biggest challenges. The other challenge, I guess, that it's the big challenge for a lot of the registries and a lot of infrastructures like ROSA is ongoing long-term support. We can do this until 2025. And then after that, we need to, again, find another venue that will support the infrastructure. We've been very lucky in the last few years and in the next couple of years. But after that, we, again, won't have the resources to have this long-term ability to plan, But I think that's not just a challenge that my team experienced, a challenge that most registries and resources like ours face.
So, Professor, I've got a number of questions about the data sources that you have in community care. There's a great deal of interest, given that more Australians are in community care service settings in their own home or in their communities rather than res care. Can you talk a little bit about what might be on the ROSA planning platform for community care?
Yeah, no, absolutely. So currently the historical data has all of the home care and home and community care services, and then the CHSP services and the home care package services. So we have recently started to use the home care service data quite substantially for a number of things. Like I said, we develop quality and safety indicators for home care package support recipients. We've also have done a lot of this integration of healthcare services analysis now in home care recipients as well. But we do understand that all of that is about to change next year. So we're in a way holding our breath to see what the programs and the service will look like before we can make recommendations about how to monitor them. So while we have those data collections, we've done a bit of research on them, and we think we understand them well. And we also think it's really important information as a baseline for what the reform effects will be. We know very little about what's to come in regards to the home care service delivery model and how that's going to change. And we hope that a lot of the tools and a lot of the knowledge that we've developed can translate into the monitoring and evaluation of that cohort too. But I don't know. You guys probably know a lot more about what's to come than I do in that setting. So
I think that the answer to that is sadly not. But I guess a lot of the questions I've got directly relate to that very issue around the raft of reforms and how comprehensive they are, how extensive they are, how sometimes unknown they are, but also that all should be underpinned by high quality data. And there's quite a bit of concern around the integrity of the data that's currently collected or used. Any comments, Professor, from your side on that?
Yeah. Yes. No, look, I think there's a few activities that give me hope that are happening, and that is the Australian Institute of Health and Welfare is leading the Aged Care National Aged Care Data Strategy, which was one of the recommendations from the Royal Commission to create a minimum data set, to make some recommendations around information that should be routinely collected in different settings. So that gives me hope for the future, that they will try to keep standardizing some of the data collections and making them available to researchers like us and to others that can use. I also think that the value in what's in ROSA is not just the aged care data, but it's the information that we bring together from the other sectors. So the healthcare data collections have been around for many, 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 many years, and they're very stable. And so using that information to monitor a lot of the outcomes, to monitor a lot of the profile of the individuals in care helps a lot. So if the assessments change, we'll still always be able to fall back in having some of the medication history of the individuals, the hospital records of the individuals, and other data collections like that might give us a bit more information. So I am hopeful, but I do know that there will be a lot of changes, a lot of breaking series in the data, a lot of changes on, the really great information, for example, that's currently collected in the NSEF. That is the tool that the ACAT uses for their eligibility assessment. So it's, yeah, I know there's a lot of changes coming. Yeah.
Thank you. Probably time for one last question, Professor. And it, I guess, relates to all of the topics we've discussed here, but also I'm getting a number of concerns that you've been only funded to 2025. I guess I'll sort of try to summarise what people are commenting or questioning on in the background here. If you were in charge of your own destiny, without putting the dollar figure on it, what would you see that after 2025 date rolls around, what would you see ROSA transition to ideally?
Well, ideally, we would be able to get some ongoing support from, I don't think, I mean, obviously, if we need to, we'll get research support to continue the infrastructure. And there are a lot of registries that have used that model. But ideally, it would be amazing if the Department of Health could somehow find some support for an ongoing team like ours for the infrastructure itself. If providers could provide some support as well. That doesn't necessarily have to be financial, but just advocacy in general for us. That would be for the department or other funding bodies. That would also be incredibly helpful. If I was in charge of my own future, I would say ideally ROSA would be extremely well funded through a very secure mechanism for the next 20 years, because I think it's an incredibly valuable source of information. And we're always learning new things about these data that have been available and are incredibly valuable. You know, the US has been doing this for many, many years, and the value of the work that has been done over the years is just incredible. And I think that there is an immense amount of opportunity for us to do the same here and learn new things about this data that we don't know yet. So yes, if I was in charge of my own future, I would give myself funding for the next 20 years and latitude to do new things with the data as well. So, but yeah, that's probably very naive of me. So.
No, I think we all remain optimistic that that long-term, significantly important funding is considered. And I guess we've all seen the short-term responses that get traction, achieve great things, but don't get refunded. And I guess from the support I see in the direct messaging I've obtained here and online, I would think that there's a great degree of support to see that happening. So look, today, Professor, thank you so much for your time today. It's been great to learn more about ROSA and its functions. The council itself is very interested in the use of data and the importance of the integrity of the data that we do use, and we're very keen to be currently working, as you know, with some of our colleagues from University of Queensland and soon to release a white paper on the industry's views on this. So your presentation today has been really important and essential in those considerations. We know that we will continue a dialogue with ROSA and about data on many areas, but today I'd just like to, on behalf of everyone in attendance, thank you for your contribution to today's webinar. Thank you.
Oh, thank you. Thanks for the invitation.
Many thanks. And just to conclude today's session, our contact numbers are there. As we mentioned earlier, this, with the permission of ROSA, we will be loading up this presentation shortly. We know that those webinars are highly accessed after the point that we do the webinars, and people are very disappointed when we're unable to share those posts these times in their busy schedule. So our next webinar is coming up in November. We're yet to confirm the finer details, but if you're on our mailing list, you will get it. And if you're not, send any of us on the screen now your details and we'll ensure that you do. Again, thank you, Professor Maria, for your presentation today, and thanks everyone for their attendance.
Lovely, thank you.